the other people they become an apprentice and they go work, and as they graduate, they're not just sent back out to society, they're actually sent out with some kind of viable skill that they can become taxpayers and they can become pillars of the community. And I believe that we have a spot available for a 10-bed detox at our location in Bangor, Maine. And I would like to see somehow we can collaborate and that we could be able to continue to be a help, not only to the city of Bangor, but to the epidemic that Maine is facing. Thank you for your time.
And we thank you very much for being here today. Thank you all who came down to be your presence here today. Thank you. Representative Grant.
Thank you, Madam Chair. Do you have a comprehensive list anywhere of the different faith-based initiatives around substance abuse that are available in Maine?
No, I don't. I don't know how many other faith-based. I know a lot of people that say they're faith-based also allow replacement drugs, and we're into 100% abstinence of all drugs and medications. And in detox, we actually detox men and women right in our program without any replacement drugs at all. But no, I'm not sure of that stat, ma'am.
And do you have any follow-up data that shows the effectiveness, the long-term effectiveness of your
Yeah, I do. In fact,
can you provide that for us?
I can do that. I can actually send it to Heather. I've been corresponding with Heather. I couldn't pronounce her last name, but she's out of the country, I guess, for a couple of days. But I've sent her some of that information already, and maybe she can forward that on to anyone else who would want any of that. Okay.
Any other questions? Thank you. Thank you again for doing that. Allison Webb?
She's there.
You've been very patient.
Thank you for your flexibility earlier.
Welcome.
I'm going to combine my testimonies. Is that okay on both parts of the bill? Are we halfway now?
That'll offer a very good transition.
Okay, great.
Since you're the last one on the blue sheets.
And I'll probably take about 5 minutes instead of 4. Good afternoon to all the committee members and chairs. My name is Allison Webb. I am a resident of Portland, and I'm here today as a private citizen to speak in favor of the proposed legislation. I am a public health professional. I am a member of the Maine Harm Reduction Alliance, a member of the Maine Public Health Association, a member of the Portland Recovery Community Center, and a founding member of the Maine chapter of Young People in Recovery, even though I am neither young nor in recovery. I am actually a recovery ally, which means that I support people in recovery in any way that I can. And I invite you to join me in that journey. It's rewarding and it's wonderful. I'm going to go just directly to my points and the specific points about the testimony, because I think we've gotten the gist of those of us that are in favor of this legislation. The first thing that I would like to say is that as you are developing the section of the legislation that deals with grant school for law enforcement in jails, I would hope that there would be provisions in the state dollars that are being spent that assure us that the people who are being sent to treatment are going to evidence-based treatment. And the reason I say that is because law enforcement officers who have stepped in to fill the gap, who I commend, I can't believe what they are doing, and it's truly amazing. They're not trained addiction professionals. And so I want to be sure that when that transition happens for an individual who's looking for treatment, that they are properly placed in proper treatment. And I've got a link in my testimony to what's called the ACM criteria, how a person is placed in proper treatment. The legislation also around these grants, the legislation that funds law enforcement officers, says to facilitate pathways to community-based treatment, recovery, and support. And I'm not really sure what that means. I think a better language would be to facilitate appropriate treatment, period, or evidence-based treatment, period. I would be cautious about the language which is in there because if a person who has substance use disorder needs residential treatment or who needs hospitalization, that may be excluded by this language. I'm not really sure. I'll also say, around these grants, in my professional work, I've conducted a lot of evaluations of public health projects, substance use programs. And in that work, I can tell you that it's really important to identify the objectives of your project at the outset before you decide that you're going to evaluate it. And so what I'm seeing here of a report that's due to the Criminal Justice Committee for these grants, that report is sort of an evaluation of how those grants were used. And it's sort of that the objectives of the program are cost effectiveness, reduce drug use, and reduce recidivism rates. And so if that's the case, if I'm reading that right, I would encourage you to add referral to appropriate treatment or referral to evidence-based treatment. And again, you're spending state dollars, and I understand the reason for the report is to make sure that those dollars are spent appropriately. So making sure that you've identified the goals or the objectives of what the money is to be spent for, and you figured out ways to measure it. I would also add that if there is to be an evaluation of this aspect of the legislation, and if we get into a broader conversation about evaluation of the way the state's dollars are being spent for treatment now, and is it working, and we can't spend money yet on treatment because we need to know what's working and what's not working, I would encourage you to look at an evaluation of the way law enforcement funds are being spent around drug use. If we're going to do an evaluation, this is from the Press Herald newspaper, reporting way out today. If we're doing an evaluation around treatment, we're going to do an evaluation around law enforcement. It's only fair. The other points that I have to do with the prevention, treatment, and recovery aspects of the bill. The first thing that I would say is that in Maine, we've actually done a bang-up job with prevention. It doesn't feel that way because there's so much news around overdose deaths, but in fact, lifetime use of alcohol, lifetime sniffing of glue and paint, lifetime misuse of prescription medications, past 30-day alcohol consumption, past 30-day binge drinking, and past 30-day misuse of prescription medications in our high schools have dropped. That's like really good news, and we don't really hear very much about that. So the only drug at this point that we haven't had much success with our youth is marijuana. So I would really take issue with my friends who are promoting the use of medical marijuana for something that it has never been proven to be effective for. At any rate, take a good look at the prevention side of things. It's working, let's keep funding it. So you may think about that as you're shifting funding to the legislation. Regarding treatment, we've heard lots of conversation about evidence-based treatment. I would really encourage you not to get bogged down into the details of social detox or opiate detox or medication-assisted treatment or any type of treatment for severe opioid use disorder or alcohol use disorder for any substances. We have addiction professionals. They know how to do this work. Your job is to create policy and provide funding and support for them so they can do their job well. It's not to be legislating about medication-assisted treatment, or methadone, or Suboxone, or anything else. And the last point that I'll make is again, in support of the funding of the legislation for recovery centers. I think that is amazing. It's wonderful. In my experience as a recovery ally, people in recovery actually know what they need to get into recovery and stay in recovery. And so I would urge you to maintain that level in the bill or increase it. To fund peer support recovery centers that are governed by and run by people in recovery. That's a little bit of a change than what's in the legislation, but typically those recovery centers that work best are governed by people in recovery. So thank you for your time. I went over a little bit, and I'm happy to answer any questions.
Thank you, Alison. Questions from any of the three committees? No, seeing none. Thank you. You want to introduce a transition here, or?
Sure, thank you.
Representative Frog?
Thank you. Just before we move on, I don't know if Senator Cates' question was documented from earlier, that we can make sure that the budget office is asked about the cost. So I just don't know. don't know if Maureen captured that. I just want to make sure that the transition that is sent off for our work session.
Okay. You have a,
Yeah, thank you, Mr. Chairman, thank you, Representative Pryor. I think a number of us have questions about the funding in the bill. Where the money is, how it's allocated here, where it's coming from, and particularly as it relates to the administration's suggestion that we don't need to worry about that part of it. I don't understand that. And so for the work session, if we can try to have people here from both the fiscal office as well as the administration budget office, so we can sort that out.
And I would think that perhaps criminal justice would want to have a conversation with them initially before it comes back. Great, thank you. Anything else before we make this transition? Is there anyone else who would like to offer testimony on parts A and B of LD 2599? Those are the sections that deal with state and local drug enforcement, law enforcement. Okay, if there isn't, we're going to transition to the second part of our.
criminal justice, thank you.
Well, I didn't think that. We will transition to our friends in criminal justice. Thank you for spending this time with us. We look forward to your report back. What we're going to do now is we're going to bring Public Utility Service members here into the middle of the horseshoe, and we would ask our criminal justice colleagues who would love to have you stay, if you would transition to the outside of the horseshoe, that would be great. Just a couple other reminders. If people are in the audience who are here for parts A and B and you are not planning on testifying on parts C, D, and E, if you would be willing to leave the room so that those people who are planning on testifying on C, D, and E would have room, you're welcome to go to the Welcome Center and listen to transportation and listen to the proceedings there. Okay? And it's going to take just a minute to transition, but please don't go anyplace immediately.
Advantage of this moment quickly.
They can do a lot of that now. I think the thing they don't like is you ask them, it's supposed to be
How long plan to leave it open? I know you want to air it out. Oh, come on now.
I know, somebody's mentioning the town.
No problem. I'll be sure to get you. No, it's good to air it out. Yeah, there's stuff he's looking at.
I have a well.
Green Bay and Packers.
How you doing? All right. That was good. I had a big bag. I didn't just have a little bag back there. I was like, I'm gonna have a big bag. I think the weirdest day is the skip process. I think the weirdest day.
Is that a main story or is that Okay, when you shut that window down.
Your old bones getting cold?
Yeah. It was good for a while.
It was good to circulate the air a little.
Did you get lunch?
Not that much. Yeah, good,
Did you
John.
guys get lunch? Mike, did you get lunch?
Good. No.
Yeah.
Well, I had a little,
You said eat. I want you to sit.
I had a snack.
We ready to go? Everybody on board? All right, we are back on. Second portion, parts C and D. First up, I'm going to pull Department of Health and Human Services up, and for informational reasons over the internet and so on, we are joined again by many more members of the Health and Human Services Committee. sitting on the inner horseshoe, and we've got a few members of criminal justice public safety who have graciously decided to stay on and listen up. So, as the microphone button is figured out, there it is. You're on.
Not as easy as it
Good afternoon.
Good afternoon. Senator Hamburg, Representative Rotundo, members of Appropriations, Senator Brakey, Representative Team, members of Health and Human Services. I am Nick Adolphson. I'm the Director of Government Relations and Policy at the Department of Health and Human Services. And I'm here to speak in opposition to a couple of key parts of this bill, LD 1537, an act to combat drug addiction through enforcement, prevention, treatment, and recovery. Senator, my testimony is more than 4 minutes. I see the clock has not started.
That's
Roll. All right. The challenges of substance abuse are not new and are not unique to Maine. This state and our country have been fighting the drug war for decades and seeking resources to effectively treat substance abuse addiction for years. Most notably, our state, like many, has spent countless years addressing the crippling addiction of alcohol abuse and the devastating consequences across our society. Over the last 15 years, Maine has confronted the serious challenges of prescription drug abuse, drug diversion, and the rise in meth labs around the state. Today, Maine faces its latest challenge in the form of a deadly opiate epidemic. In recent years, that problem was manifested in increased overdoses and targeting of our state by highly organized violent drug dealers from cities such as New York, Lowell, Massachusetts, and Bridgeport, Connecticut. In 2014, there were 208 drug overdose deaths in Maine. Of those, 57 resulted from heroin use and 70 from prescription drug abuse. Final 2015 figures are not yet available from the medical examiner's office, but total overdose deaths in 2015 are on track to exceed 240, with an even higher percentage this year of those deaths due to heroin. Maine is not alone in facing this challenge. According to data from the National Institute on Drug Abuse, overdose deaths from opiates are on the rise nationally, with heroin overdoses increasing by nearly 500% between 2001 and 2014. Indeed, the Portland Press-Herald reported yesterday that New Hampshire is expecting more than 400 deaths from heroin and other opioids this year. The deadly grip of addiction takes lives, tears apart families, increases crime, and affects the most vulnerable among us, such as newborn babies tragically left to detox in a hospital. In Maine, arrests due to drug offenses have more than quadrupled since 2010, and the number of babies born to moms struggling with addiction has increased by 500% in the past decade. 75% of heroin users began their addiction with a legally prescribed opioid, and Maine ranks as one of the top per capita prescribers of opioid pain medications in the nation. Recent morbidity and mortality weekly report data from Maine's prescription monitoring program shows that in 2014, Maine healthcare providers wrote 1.2 million prescriptions for 324,000 individuals, or approximately 1/4 of our state's population. While the Department of Health and Human Services, through Maine Care Policy and the PMP, has made considerable progress in addressing this issue, the overprescribing of opioids has undoubtedly helped fuel heroin abuse in Maine. Clinicians need to recognize how their opioid prescribing habits impact this crisis. Maine Care's pain management protocol is working to align itself with the newest federal CDC guidance regarding opioid prescribing limitations. We must stop the development of new cases of addiction with this upstream strategy and hope to work with the state medical associations in educating providers on the incredible risks of opioids. It's time to take the next step in ensuring that in helping people with pain, we're not inadvertently contributing to an addiction. While DHHS plans to lead through Maine Care policy changes, we would be supportive of legislative action to align the state with the federal CDC guidance and mandate the use of PMP to create even more accountability. The LePage administration shares the view of many that there is certainly a drug problem in Maine, As the governor and Commissioner Mayhew have stated, the solution will require a statewide community effort that includes additional law enforcement resources, ensuring our children receive adequate, informative education about the perils of drug abuse, and greater effectiveness in our substance abuse treatment programs. We cannot alone spend or arrest our way out of this societal challenge. Maine spends more than $70 million annually on treatment and prevention for substance abuse, serving approximately 25,000 people struggling with addiction. Eligibility changes in Maine and Medicaid have resulted in a reduction of overall caseload numbers over the past several years, but the number of individuals receiving substance abuse treatment in Maine has remained largely stable. Currently, Maine spends more than the national average on substance abuse per capita and per our GDP, ranking higher than many of our peers in other New England states. Medicaid accounts for more than 2/3 of the department's total spending on substance abuse treatment and prevention, and for about 80% of the total individuals served. Substance abuse treatment modalities in Maine care include, but are not limited to, medication-assisted therapy, clinics, counseling, inpatient and outpatient treatment, residential treatment. Similar treatment options funded through the general fund, the substance abuse block grant, and other federal resources are available for Maine's uninsured. DHHS expends the latter funds through contracts with substance abuse providers. In each of the past 5 years, the department has lapsed funds in unspent contracted dollars. There are nearly 240 licensed substance abuse providers in Maine. More than 40 of those have contracts with DHHS through the Office of Substance Abuse and Mental Health Services to specifically provide treatment for the uninsured. Resources at samhsa.gov help offer an overview of substance abuse providers across the state, identifying geographic locations and the services that are provided there. The latest data from SAMS identifies an average wait of 7 days for intensive outpatient treatment and 14 days for outpatient treatment services. Whereas increased drug abuse in Maine drives a corresponding need for additional treatment, the LePage administration believes, first, that it's imperative for providers to fully utilize contracted funds. More than $500,000 in contracted treatment funds lapsed to the state general fund in the most recent year. And second, that substance abuse treatment providers must do everything possible to ensure that Mainers who enter treatment complete that treatment and successfully recover. Without a commitment to the latter, no amount of taxpayer dollars will solve the substance abuse problem in our state. The department is speaking in opposition to this bill as it's written. It is important, however, for the authors of the legislation to know we are willing to work with them where new or repurposed resources would truly address a need. Regarding the bill in question, the administration has strong concerns about the prescriptive nature in which the dollars are being allocated to specific providers. For example, we question the presumed need for a detox center in Bangor rather than other parts of the state, and the requirement that such a center be administered by a Bangor provider rather than letting all Maine providers compete for the service if they desire to do so. Furthermore, the administration strongly opposes the bill's provision that would provide a non-competitive contract in seeming perpetuity to the Maine Association of Substance Abuse Providers. Since Governor LePage took office, Maine's executive branch has made major reforms in its procurement process. Unless specific circumstances exist that prohibit a state agency from competitively procuring a service, state entities always conduct a thorough, competitive procurement process to ensure that taxpayer dollars are purchasing services from the most qualified and capable providers rather than politically connected ones. Setting aside the discussion about the actual need for the services that MASAP would provide, the ability to sole source a contract is a useful tool when expediency is paramount, but it must be used in a limited fashion, and it is not designed for long-term procurement, such as the bill suggests. To carve out a contract for a specific organization in the law is to give that organization a tenure status that eschews accountability and performance. More than just adding resources, as this bill largely does, addressing our addiction problem requires a holistic review of the entire system. The department is currently focused on making policy changes and initiating action in several areas to help address addiction in Maine. The department is undertaking efforts to Strengthen opiate prescribing limits. I'm just going to go down through the bolded pieces of this. Utilize the PMP for greater transparency and accountability related to opiate prescribing. Launch a 24/7 phone and web resource to provide immediate support for persons with addiction and clinicians. Initiate a pilot project using Vivitrol to assess its broader use in addressing recovery from addiction. Provide additional support to pregnant moms struggling with addiction to encourage long-term recovery and improve birth outcomes. And reform the payment structure for the uninsured to focus spending directly on persons with addiction. There's much government can do to help resolve the societal challenge. But government is not the ultimate solution. The solution is in the community, or the communities that each of you represent. No amount of treatment, funding, or improved process is going to fix the problem that we face. Treatment, by its very nature, is dealing with the problem after the fact. Can we better help those that have fallen into the trap of addiction? Can we assist those whose lives are being ruined by tragic addictions? Yes. But Maine's drug problem won't be solved by a government treatment program. We need families, friends, neighbors, school teachers, coaches, doctors, and communities to step up and address the root causes of drug use and drug addiction before treatment is ever an issue. Thank you, and I'm happy to take questions and happy to be available myself at the work session and also some of the team at the HHS.
Thank you, Nick. I'd like to lead off here. Several times you mentioned the PMP. And I'm on top of page 2, bottom of the first paragraph. Mandate the use of the PMP to create even more accountability. Can you give me a little bit about prescription monitoring program?
So the prescription monitoring program is a system in which prescriptions for opiates, opioids, and some other drugs, and probably people behind me that can give you much more detail, but it's where those prescriptions are entered. A doctor has an option to get into the PMP, and they all are now, I believe by now, they all should be registered to be able to use the PMP. They can get in there and see that, oh, Nick Adolphson has a prescription with another doctor, and now he's looking for one from me, and identify that I'm a problem and therefore not giving the prescription. And it's much bigger than that, but that's in essence its capability. There's also options, and if you look near the end of the
doctors are
testimony,
registered in the PMP, but you use the word option. It is optional for them to use.
they do not have to get on the PMP to check the system to determine whether the patient they're prescribing for is using another opiate that was prescribed by another physician.
So by your statement here, then it would be a mandatory. Be mandatory for the doctor to access the PMP before he writes you a script.
Not every script,
But
for certain types of drugs.
Okay.
Yes.
Thank you. Questions, Representative Jordan?
Thanks very much. Thanks for being here. Appreciate it. I want to ask you about the lapsed funds. It looks to me like you're talking about more than $500,000 returned because they weren't needed. Yet we've heard, this whole morning I've heard people talking about how they couldn't find resources. They had to go out of state. They had to go somewhere else. Can you just try to reconcile those two things for me?
In the Office of Substance Abuse and Mental Health Services, we contract for a specific amount of dollars with specific agencies for the entire year. We pay them in 1/12 increments. And so they get paid, they then submit their bill. If they do not utilize the entire amount that they've been paid, it gets trued up in the next month. So we go through the year this way, and if a treatment provider does not use all of the resources in their contract, it becomes lapsed. And I could only surmise why a provider would not. It may be a cautionary thing, or fear of going over, they don't want to go over. I'm not sure, but I do know that they are not used. And we are more than happy to work with providers, and we've communicated this to providers, that if it looks like they're going to have money left over, they need to talk to us. And if we can see from our system that they may have resources left over, we're going to be talking to them so that those resources can be moved where they will be used. And on the opposite side of that, if a provider is going to run out of resources to provide treatment for the uninsured, they also need to notify us in the case that there are resources left on the table that could be re-encumbered into their contract and utilized.
But I guess the question I had is, I mean, so we're getting money back, yet we're hearing again that people aren't getting the treatment. Why aren't they getting the, what is the different story I'm hearing from them versus the story you guys are saying? I mean, I'm not trying to imply that you're lying. I'm trying to figure out what's the difference here? Because some people, a group of people are saying it's very hard to find treatment. You're saying most people get treatment within 14 days, and
That's the average for outpatient therapy. To be able to connect that disconnect is challenging. I think the answer is more money doesn't always equal more treatment or better treatment. I think there's probably some reporting that could be improved by on both ends of the spectrum. But I think at the end of the day, more money doesn't always equal more treatment.
thank you.
Yeah, thank you very much. Thank you for being here. On page 2, you make reference that we spend about $70 million annually on treatment and prevention. I wonder if it'd be possible to break that down as to the categories, how much each category and the number of people that was served by that money. For example, I know that some is for childbirth, some of the children born, and that must be one category, I have to assume. Then you have pregnant mothers, and you have et cetera, and then on where that money comes from. In other words, was some of that Maine care? Was that an appropriation that came through the Substance Abuse Office? And so 70 million sounds like a lot, but I can't figure out what the cost is for each type of treatment and how long that may be,